So you can start seeing the numbers going up. And when I start, Owen, if you want to talk for a minute or two about BSI, that's great. Take your, feel free to do whatever you want. So, that's great. We have already 300 people online. Now, good evening, everybody. I hope you can hear me all okay. This is the first time I'm running the webinar from my iPad. Can you hear me all fine? So we have a lovely webinar today with Breast Surgery International. It's great to have people from all across the world. So we have 4 talks about high-risk lesions and B3 lesions. It's mainly B3 lesions. The first talk will be about imaging and diagnosis by Nisha Sharma from the UK. Then about pathology by Abeer, Shaaban, also from the UK. Then surgery from Kavitha, Daester from Switzerland. And then we have communicating B3, how to tell your patients about the diagnosis, mainly from Giuseppe Catanuto from Italy, followed by discussion. And we have in the discussion, we have Owen from Australia. We have Omar Yousef from Egypt. We have Sharon Chan from Hong Kong, who's currently now in Japan. And we have Kerstin Sadelin from Sweden. So it's lovely to have you all together. Owen, do you want to put a word or two about Breast Surgery International before we start the talks?
Thank you, Yazan, and thank you everybody online. We're so delighted to be invited to join you, accepting the invitation from Yazan. BSI is Breast Surgery International. We're an integrated society of the International Surgical Society. And we, like all of you online, are breast surgeons who are dedicated to excellence for our patients. So, we seek membership from all countries and all people interested in the practice and development of breast surgery who pursue research in various aspects of breast disease. So please feel free to look at us on the website. We have a biennial meeting, and it's a very convivial group of wonderful people, and we're pleased to have some of our counsellors involved in this meeting. And thank you again, Yazan, and we'll talk more as we go along. That's
great. And let's remember Ricardo Pardo is again with us. Hi, Ricardo, how are you? So Ricardo is going to run an immediate translation to Spanish. So if you want to listen to the talks in Spanish, just click on the globe and choose the Spanish channel. And Ricardo is doing a great job as usual. So let's start with the talks. And we have Nisha Sharma first. So Nisha is one of the radiologists in Leeds, and she's done lots of work on B3. And Nisha, along with many of the speakers today, is also involved in guidance writing, not only in the UK, is also in Europe. So Nisha is going to talk about imaging and diagnosis. Imaging, so in the next 15, 20 minutes are all yours, Nisha.
Thank you. I'm just going to share my screen and can I just check that you can see my screen okay?
I can see it fine, Nisha. You just need to make it as a full, yeah, that's great.
Right, thank you. So first of all, I'd like to thank Yazan and the committee for inviting me to speak today. I'm talking about high-risk lesions, and I'm going to focus on the imaging and diagnosis. So as Yazan said, I'm a consultant breast radiologist and director of the breast screening programme working in Leeds and Wakefield. So purpose of my talk, I'm going to define high-risk lesions. I'm going to talk about the importance of imaging, and it would be remiss of me not to talk about the role of imaging in managing these high-risk lesions using vacuum-assisted excision. Now, high-risk lesions, or in the UK, we call these B3 lesions because histologically they're defined as lesions of uncertain malignant potential. So these are entities known to be heterogeneous, meaning that the area sampled by needle core biopsy, whilst benign per se, may not be representative of the whole lesion, or because the lesion is known to be associated with DCIS or invasive carcinoma, or both may apply. Now, these high-risk lesions are also important because we know that when we do further sampling, we're likely to identify cancer, so we'll upgrade them to malignant lesions. but we also know that they have an increased risk of developing breast cancer in the future. And as you develop atypia, your increased risk increases for the risk of developing breast cancer. So in the UK, the breast screening programme, high-risk lesions account for just under 7% of all our core biopsies. And I think it's important to remember that high-risk lesions, this is a histological diagnosis that cannot be made on imaging alone, as you need histology to make the diagnosis. Now, because in the UK, we will categorise them as B3 lesions, often people will confuse them with BI-RADS3 lesions. Now, BI-RADS3 is an intermediate category in the breast imaging reporting and data system. So this is an imaging finding, and it's a finding placed in this category is considered probably benign, with a risk of malignancy more than 0 but less than 2%. And lesions that are categorised as BI-RADS3 are often put on follow-up. So if one important point from the talk is that BI-RADS3 lesions do not equal high-risk lesions. And to illustrate this, we have 4 mammographic abnormalities. We have an area of calcifications, we have a mass, we have an architectural distortion, and we have an asymmetry. So as a radiologist, when I'm looking at the mammogram, I see a mammographic abnormality, and I'm not able to tell you if it's benign, if it's a high-risk lesion, or if it's a cancer, because I need to do a biopsy in order to get the histology. Interestingly, in this group, the calcifications on the left were a high-risk lesion. The mass was a fibroadenoma. The architectural distortion, which looks like a cancer, was a radial scar. And the asymmetry was fibrocystic change. So this just highlights the point that imaging from imaging alone, you cannot diagnose a high-risk lesion. So in the UK, because following the Marmot review, which was published in 2012, we were focusing on minimising overdiagnosis, which results in overtreatment. And there was a lot of emphasis put on radiologists in minimising overdiagnosis. But as I showed you in the previous slide, it's very difficult for us to know what is overdiagnosis and what is not based on an image. And therefore, really what you have control over is overtreatment. So following the Marmot review, there was a focus on minimising overtreatment of these high-risk lesions, because it was recognised that most of these women were being treated with surgery, and ultimately the surgery was benign. So we published our guidelines as part of an appendix for the assessment guidance document in breast screening in 2016. And then we published our full guidelines in clinical radiology in 2018. Now, when we developed the guidelines, we realised it was very important to define the terminology, because if you don't create simple definitions, people will confuse the terminology. So vacuum-assisted biopsy is where vacuum biopsy is replacing the 14-gauge core biopsy to make a diagnosis. So the aim is to take the minimum amount of tissue to make a diagnosis. And in the UK, 80% of breast units are now performing vacuum-assisted biopsy for stereotactic biopsies rather than using the 14-gauge core biopsy. Diagnostic vacuum-assisted excision is where vacuum is used to replace the surgical diagnostic biopsy. So the aim is to take plentiful tissue, and we're aiming for about 4 grams of tissue. If the lesion is small, we will excise it in its entirety, but if it's large, what we will do is obtain representative sampling. And just for completion, we have therapeutic vacuum-assisted excision, and this is where we're using vacuum to excise cancers, but this is not for the remit of today. So again, just to explain the importance of vacuum-assisted biopsy, this is a conventional 14-gauge core biopsy where you will obtain about 15 milligrams of tissue. When you start doing vacuum-assisted biopsy, you obtain better quality and volume of tissue. So a 14-gauge vacuum biopsy will give you about 40 milligrams of tissue. And when we're talking about vacuum-assisted excision, we're talking about using a 7-gauge or 8-gauge needle, which will give you about 300 milligrams per core. So when we developed our guidelines, it's very important that you have clear objectives. What are the guidelines trying to achieve? So for us, in terms of managing these high-risk lesions, we wanted to improve the preoperative diagnosis of cancer. So we wanted to identify the cancer prior to surgery to mitigate women from having 2 operations. And this meant that they could have one definitive therapeutic operation if cancer was identified. And we wanted to reduce the number of women going for a surgical diagnostic biopsy. So when you look at the pathways, prior to the implementation of the UK pathway, all high-risk lesions on core biopsy meant that you needed more tissue. And that meant that all these women ended up having surgery, which was a general anaesthetic. It required a wire localization, and the lady would often end up with a surgical scar. With the new pathway that we've implemented in the UK, we're saying, yes, we agree, we need more tissue, but we can do this using vacuum-assisted excision. And we have said that all high-risk lesions are eligible for vacuum-assisted excision except papillomas with atypia, spindle cell lesions, and fibroepithelial lesions. And when you compare with the European International Consensus Guidelines, they agree with us, except when it comes to the management of atypical ductal hyperplasia. Now, this is an example of a flow diagram for one of our high-risk lesions, and we have flow diagrams for all the high-risk lesions. So the biopsy, initial biopsy might be 14 gauge or a vacuum-assisted biopsy, but you'll note that in our flow diagram, multidisciplinary discussion is really important. Because if we identify a high-risk lesion, the first question is, can we perform vacuum-assisted excision? Yes. Technically, can we do it? Yes. Then that's what we go on to do. And then we discuss the results of the vacuum-assisted excision at the multidisciplinary meeting. And this is just an example of a lady who in breast screening was recalled because she had a mass on her mammogram, which was new. On ultrasound, we have this lobulated mass. We did an ultrasound guided core biopsy, and it was a fibroadenoma with in situ lobular neoplasia. I performed ultrasound guided vacuum assisted excision, excised the lesion, and it was a fibroadenoma with lobular neoplasia, and she's gone on to 5-year follow-up, so no surgery. So, as I said, our guidelines are different. The management of atypical ductal hyperplasia varies with the UK guidelines and the international consensus guidelines because the objectives are different. So the international consensus guidelines stated that the overall underestimation rate should not exceed 5% for invasive cancer and 10% for DCIS. And yet we know that for ADH, the upgrade rate can be up to 40%, depending on the literature that you look at. So because they've set this objective, that is the reason ADH is managed with surgery, whereas in the UK, our objective was to identify the cancer preoperatively, and that is why we're performing vacuum-assisted excision. The National Cancer Comprehensive Network also recommends surgery for ADH. The American Society of Breast Surgeons, again, also recommends surgery, but they do state that if it's small volume ADH, completely excised by core needle biopsy, then you could just observe, providing imaging and pathology are concordant. The American Neuroendocrine Society, again, agree. They say if you've got a high-risk lesion and other atypical lesions, then you should do surgery. But if it's just ADH and it's for a focal group of calcifications and it's small volume, then you may consider surveillance. Otherwise, all should be treated with surgical excision. Our guidelines state that we can do vacuum-assisted excision, and the German guidelines also recommend surgery. So you can see that the UK is managing ADH different to the rest of Europe and internationally. Now, I'm just going to present some data from the English National Breast Screening Programme. So we implemented the guidelines, and this was an audit to look at the impact of the guidelines. So we collected data from the 1st of April 2018 to the end of March 2019, and we extracted data from our national breast screening system, and we divided women to those with high-risk lesions with and without atypia. So during this time frame, we had 2.2 million women who were invited and attended for screening. We had just under 85,000 women were referred for assessment, and of those, just over 40,000 had a core biopsy, of which 3,355 were high-risk lesions or B3 lesions. We diagnosed 556 cancers, giving us an upgrade rate of just under 17%, which again fits with the literature. And our upgrade rate for B3 lesions with atypia was significantly higher than those without atypia, which is not surprising. With the introduction of the guidelines, just under 74% of B3 lesions with atypia and just over 65% of B3 lesions with no atypia have been managed with vacuum-assisted excision alone, not requiring surgery. And this is another piece of work that we did in Leeds because we wanted to look at the cost effectiveness of implementing vacuum-assisted excision as an alternative to a surgical diagnostic biopsy. So they compared the two pathways, and we used data from Leeds, which we'd previously published, incorporating 398 patients. We had individual patient-level data on all these cases. So the main outcome was to look at the economic impact in terms of cost of various scenarios using an analysis of extremes and probabilistic sensitivity analysis. And what we showed was that vacuum-assisted excision reduced the cost per patient by £1,510.75. So this shows that vacuum-assisted excision replacing the surgical diagnostic biopsy is cost effective. Of course, if you were to implement core biopsy, vacuum-assisted excision, and then surgery, this would not be a cost-effective pathway. So to conclude, high-risk lesions are a histological diagnosis. They are a heterogeneous group, and Professor Shaaban will go into this in more detail. But the objectives of the UK guidelines have been met because we've reduced the number of women who've gone for surgery for managing these high-risk lesions, and we've improved the preoperative diagnosis of cancer. Because we're collecting data at national level, this will help refine the pathway and support further research in this area. We've shown that it can be a cost-effective pathway, and certainly our surgeons in the UK are grateful of the pathway because it's allowed them to focus on cancer patients and be able to proceed with doing therapeutic mammoplasties or cosmetic surgery that will improve the outcome for patients. And the patients find this a patient-centred pathway because they're avoiding surgery. They're still being monitored. And remember, most of these lesions were not cancers. So they're avoiding surgery for benign lesions. So I'm going to stop sharing there.
And that's great talk, as usual, Nisha. A beautiful review of the radiology of B3 lesions. And we have it's great to have more than 550 people online. And I'm much more relieved now since the volume and the voice and everything is working fine. And the next speaker will be introduced by my colleague, Omar Yousef. Omar?
Well, it's my pleasure to introduce Dr. Abeer Shaaban, whom I'm sure most of you know her very well. She's a consultant pathologist in Birmingham, and she's going to speak about the high risk and B3 lesions pathology, which is the integral part of today's webinar. Please, Abeer, start.
Thank you, Dr. Omar. Thank you for the kind introduction. A pleasure to be with you all, wherever you are. And I'm going to cover the pathology aspects of the B3 lesions. This is a non-exhaustive list of B3 lesions, or what we call lesions of uncertain malignant potential. The most common of them are flat epithelial atypia, atypical intraductal epithelial proliferation, which is the same as ADH, but in the UK, we prefer this term in the limited amount of core biopsy or diagnostic VAP, since it is a quantitative terminology. Lobular in situ neoplasia that includes ALH and LCIS, papilloma with or without atypia, both are regarded as B3, radial scar, and other less common lesions, cellular fibroepithelial lesions, mucocele, and miscellaneous group. We know from the literature that the vast majority of these lesions on further sampling will turn out to be benign. However, in about 15 to 20%, these will harbor either in situ or invasive malignancy. And there are several factors that determine the upgrade rate on further sampling. Depending on whether you're looking at screen detected or symptomatic patients, the method of biopsy, a small 14-gauge needle versus a diagnostic VAP, combination of lesions, size of lesion, but by far the most important factors that determine the association with malignancy is the presence of atypia. And this is a good paper on systematic review and meta-analysis of published literature, including 129 full-text studies from 15 countries. They found that the total B3 upgrade rate was 17%, and the highest upgrade was with ADH or atypical intraductal proliferation. And they concluded from the evidence that this risk can be managed by vacuum-assisted excision. And just to show you the effect of atypia, presence or absence of atypia. So this is a papilloma without atypia. That's the percentage of upgrade. This increased dramatically if you have atypia to 37%. Similarly, radial scar with no atypia and radial scar with atypia. So atypia is the strongest predictor of upgrade. And when your pathologist says atypia, we mean one or both of those terminologies, either cytological atypia, where you have abnormality or cytological atypia, some changes that are not yet fully malignant, but localized to the cells and without any abnormal architecture. Sometimes the cytological atypia is combined with architectural atypia, where you find an intraductal proliferation. And sometimes these look really interesting, look like animals, as you can see, and this is abnormal when you compare it with the normal architecture of breast. So this is flat epithelial atypia, and this is atypical intraductal epithelial proliferation, or ADH, which includes both architectural and cytological atypia. As we heard, these lesions are managed by further sampling, but because they are associated with low risk of subsequent breast cancer, we just need to adequately sample them to rule out coexisting malignancy. And this is the UK guideline paper that Nisha referred to, showing that second-line VAP, or vacuum-assisted excision, is a method of choice for further sampling of B3 lesion. So this applies to all types of B3 lesions except papilloma with atypia, because we would need to examine the whole thing intact to assess the extent of atypia to differentiate between atypia in a papilloma and DCIS. Cellular fibroepithelial lesions where Phyllodes tumor is suspected, would like to assess it in a surgical excision to assess the margins, and the miscellaneous group of B3 lesion, including spindle cell lesions, vascular lesions, adenomyoepithelioma, apocrine atypia, and so on. So you've seen this graph before, and this shows us the process, the pathway for managing atypical intraductal epithelial proliferation or radial scar with atypia. This is the management pathway for the miscellaneous lesions. All of them, once diagnosed on core biopsy and following MDT discussion, they would go for surgical excision, and VAE is not recommended. As we heard, the other international guidelines are a bit different, with ADH favoring surgical excision, and similar to the UK, Phyllodes tumor should be excised. Just to let you know that there are some guidelines in development by EUSOMA for the management of B3 lesions, and we hope that these will be available this year. This was a recent paper on the effect of delayed sampling of B3 lesions during the COVID pandemic, and to see whether this has resulted in a change in the upgrade rate. So whether the delay increased the upgrade rate, and reassuringly, this was not the case, and the upgrade rate during the COVID pandemic, following a bit of a delay, was not different from pre-COVID. So if we go through the most important lesions, flat epithelial atypia, usually identified because of the presence of calcification, which are these blue blobs there. And these are dilatation of terminal duct lobular units lined by hyperchromatic atypical columnar lining. By definition, these are low grade. Architecture complexity is not seen there. If there is architectural complexity, this is ADH or DCIS on top of flat epithelial atypia. If the same lesion has high-grade nuclei, this is no longer FEA, this is high-grade clinging or flat DCIS. Unfortunately, immunohistochemistry is not helpful in confirming the diagnosis of FEA because the immunoprofile is exactly the same as ADH and low-grade DCIS. Sometimes FEA is associated with complex architecture, either micropapillary or early cribriform pattern. And if this is less than 2 millimeters, we call it ADH on top of flat epithelial atypia. So how do we manage columnar cell lesions diagnosed on core biopsy? We always examine at 3 levels. If there is no atypia, that's to say columnar cell lesion only or columnar cell hyperplasia, this is B2, provided that we sample the calcification, nothing else is required. If there is atypia, whether FEA, AIDP, or other, then we would go for B3 and go for VAE. If it is high-grade cytological atypia, this is DCIS, not flat epithelial atypia. If we have atypia on excision, we would sample well to exclude coexisting disease. We know that flat epithelial atypia shares the same molecular profile of the low-grade neoplasia family, including 16q loss, and it is associated with low-grade lesions, including LCIS, grade 1 ductal carcinoma, and tubular carcinoma. However, its progression to cancer is slow, and the rate is low and occurs over a long period of time. ADH, atypical ductal hyperplasia. It's a quantitative diagnosis, and by definition, it is not high grade. If it is diagnosed on core biopsy, in the UK, we call it atypical intraepithelial ductal proliferation and call it B3 for vacuum-assisted excision. And the reason we do not call it ADH on core biopsy is that you need to assess the whole area to make sure that the lesion is less than 2 millimeters in size. So if this is all what we have, then this is ADH. If there is more of it, then there is DCIS. So this is an example of just one duct showing this architectural atypia. When do we diagnose DCIS? If we have the atypia extending into 2 fully involved ductal spaces or 2 millimeters or more. Remember that in atypia in papillomas, the cutoff is 3 millimeters, not 2 millimeters. And this is one of the reasons why we recommend excision of papilloma with atypia to assess the size and diagnose either ADH in a papilloma or DCIS. ADH is a difficult diagnosis and it suffers from low reproducibility of diagnosis among pathologists. And this is data from the UK breast EQA scheme. This is a recent paper from Memorial Sloan looking at atypical ductal hyperplasia bordering on DCIS on core biopsy. So this is almost DCIS, but you don't have enough yet to call it that. And in the UK, we tend to call these B4, not B3, when there is strong suspicion of DCIS. And they found that the upgrade rate is higher, 40% as DCIS and 6% as invasive on excision. So management of AIDP on core biopsy is B3 VAE in UK and surgical excision in most of the other guidelines. In surgical excisions, if ADH is immediately adjacent to DCIS, we regard it as part of the same process and we call it DCIS and we ensure clear margin. But if you have just one duct with isolated AGH at the margin, surgical excision is not recommended. If we move to lobular in situ neoplasia, classic LCIS, it's a disease of premenopausal women in general. It has a specific histological appearance. It's often multifocal and bilateral, and the true incidence is difficult, but it's thought to be low, up to 3.8%. That's what it looks like. We have two types of it, but the cells are generally uniform, expanding globules, and they can be a bit cytoplasmic and more variable. But the characteristic appearance is the loss of EC-adherent gene, leading to discohesion of cells. As we see here, they have lost touch with each other. And if we do EC-adherent, this proliferation is EC-adherent negative in the majority of cases, and that's what differentiates it from DCIS. When do we call it ALH and when do we call it LCIS? Again, depending on the extent of the lesion. LCIS is a more extensive disease. So if most of the anasinus is distended and distorted by the discohesive lobular cells, this is LCIS. This is an example of ALH, which is a more limited disease. Doesn't matter on core biopsy, both of them are called B3. You can just call them in situ lobular neoplasia, and the management is the same by vacuum-assisted excision. And this is a paper that showed that the outcome on further sampling of ALH and LCIS was the same. We've always been told that LCIS can be multifocal and bilateral, and that the risk for subsequent breast cancer development, usually lobular carcinoma, is in equal proportions between the two breasts. However, recent data has shown that invasive carcinoma following ALH and LCIS is 3 times more likely to occur in the same breast compared with the opposite breast. So bilateral risk, but still the risk is higher in the ipsilateral breast. There are more recent variants of LCIS. One of them is pleomorphic LCIS or PLCIS. It's really important that we make the correct diagnosis because PLCIS is categorized as in situ carcinoma and coded as B5A, not B3. And this is an example. So large ducts with high-grade nuclei can be associated with calx here and comedonecrosis as in here. So very much similar morphologically to high-grade DCIS. So why isn't it DCIS? It's because it's EC-adherent negative and it has the features of lobular neoplasia, particularly discohesion. So it's important to be aware of this entity and code it properly because the management is different. The upgrade rate for pleomorphic LCIS is higher than classic LCIS. And PLCIS in most of the guidelines is managed by excision with negative margins. So in the UK, NCCN, ESMO, so the data support that this should be excised and managed as per high-grade DCIS. There is an anomaly here in the recent AGCC cancer staging manual that actually removed LCIS from the staging and regarded it as benign lesion, even for PLCIS. So it's no longer in this classification regarded as PTIS. In the WHO Blue Book for histopathological classification of tumors, it is recommended that PLCIS and florid LCIS are excised with margin, and PLCIS is coded as in situ disease. So when we diagnose PLCIS in core biopsy, we call it B5A. We treat by surgical excision with clear margins, and we include PLCIS in the measurements of whole tumor size. And if it is at or close to the margin, as in this case, we go back and clear the margin. So very much similar to high-grade DCIS. So what about The florid LCIS, even rarer subtype of LCIS, used to be called mass-forming LCIS or LCIS with comedonecrosis. You can remember it as a lesion that looks very much like low and intermediate grade DCIS, but it is lobular, it's EK-adherent negative, and it can be associated with calcs and necrosis too. Data in the literature is limited, but it is now recognized that it is associated with higher percentage of upgrade to invasive malignancy when compared with classic LCIS. There are no standardized guidelines for management. In the UK, if pure, we call it B4, and in Europe, generally, it is regarded as in situ B5A. In the UK, generally, we assess on case-by-case basis, but recommend excision with margin if possible. And this is what is happening in Europe as well. It's basically treated as low and intermediate grade DCIS. So just to recap, LCIS classic B3, florid is B4, PLCIS B5A. Just practical issues, first line VAP and VAE, they take longer processing, so the turnaround time is a bit longer. VAE is similar to diagnostic excision, so we rely on our radiologists to tell us that this is VAE, and therefore we do not provide any B coding. Sometimes the lesion is completely excised, and if so, we would comment on marker clip reaction and evidence of previous biopsy. Marker clips are very, very useful, so please encourage your MDT to use them, and sometimes sizing of the lesions can be difficult because we're assessing them in piecemeal, and this is just a selection of some relevant articles in your free time to go back to. Thank you.
Thank you very much, Dr. Abeer. It's an excellent talk, and I know how difficult to bring all this in just these few minutes. So thank you very much, and it rose so many questions. I think it is in the Q&A, and we will discuss them later. Yazan?
That's great. Many thanks, Omar. Many thanks, Abeer. Lovely talk as usual and very informative. Lovely slides with the little animals. We need to have that also for different presentations. We have more than 600 people online, which is great. You want to start putting the questions on the Q&A section, so when we go on the discussion, we will address the points that you want us to address. And now we have the next speaker, and now after radiology and pathology, we have surgery. So it's a great pleasure to have Kavitha Daester from Switzerland, who's going to talk to us about surgery. And Kavitha is also one of the members of BSI. So Kavitha, next 15-20 minutes are all yours.
Thank you very much. I'm just going to share my slides. Okay. Okay, can you see it okay, Yazan?
All is fine, thank you.
Okay, yes. So thank you very much, Yazan, for your introduction. And also like to thank BSI for allowing me to speak today on this very lovely topic. So I'm talking about high-risk breast lesions, but certainly from a surgeon's perspective. I really hope today that I will be able to share with all of you online my experience gained as a surgeon who completed my training in England, oncoplastic fellowship in Australia, and my day-to-day practice as an oncoplastic breast surgeon in Switzerland. Just a brief overview of what I'll be speaking on today. So very briefly, I'll touch on malignancy rates overview and diagnostic workup, which was very thoroughly covered by my colleagues, Dr. Sharma and Professor Aban. I will be talking on the International B3 Consensus Conference results, going into surgical biopsies and localization techniques. And I think the last part of my talk is probably going to be the most interesting, where I bring in some cases, surgical challenges, complications, interesting images, and some interesting cases. So you've seen this slide on my previous speaker's presentation. What we really can demonstrate here is that B3 lesions certainly are a heterogeneous group of lesions with variable malignancy rates. Certainly with atypia and ADH, you really fall into a much larger spectrum of having a higher risk of an upgrade into a malignancy. Traditionally, following a core biopsy highlighted by Dr. Sharma, the patients would be referred on for a surgical excision upon diagnosis of a B3 lesion. Certainly starting my training as a surgical registrar in England, it was definitely deemed to be a training operation, something we did very often. But over the last years, with the recent introduction of minimally invasive diagnostic procedures, we've certainly moved away a lot from surgical biopsies, especially with the introduction of vacuum-assisted excisions, certainly deemed to be comparable to surgery without its complications. But certainly from the diagnostic workup of B3 lesions, this whole area is still highly debatable, especially for certain specific subtypes, which then brings me actually onto my next slide. Now, I would just first and foremost like to thank my colleague, Dr. Constance Elken, who is the president of the Minimally Invasive Breast Biopsy Working Group, for sharing her unpublished data from the 3rd International Consensus B3 conference that was recently held in Innsbruck last year. The table here is a summary of all the votes from the expert panel. What you can identify here is exactly what Dr. Sharma actually highlighted in the ADH group. If you have ADH confirmed on a core biopsy, all the experts really recommend further excision, most of them favoring an open excision. However, majority of them would still advise an open excision despite having had a vacuum-assisted biopsy of excision with no residual imaging findings. And I think that's what really differs from the practice in the UK. For the phylloides cancers lower down, what you can really see here is that majority would recommend a excisional biopsy, favoring mostly open excision. But what was actually quite interesting with the phylloides tumors, after a vacuum-assisted biopsies, if no residual lesion was seen on imaging, majority, although marginal, would recommend surveillance with no further surgical excision. The rest of the B3 lesions, the results were really quite as expected. Following a core biopsy, an excision was strongly recommended, favoring an open excision, and following a VAB excision, should there be no residual findings on the imaging, surveillance was an acceptable choice for management. So we go into the surgical side of my talk. I think being quite a challenging area, pretty much most MDTs mandates that all B3 lesions be discussed in the MDT, and based on the MDT recommendations, some of these lesions will be referred on for surgical biopsies. Now, as a surgeon, it's really important when you're consenting patients for these procedures that you highlight that this is indeed a diagnostic procedure with a possibility for a second operation, should there be a histological upgrade. It's important to plan the incision, allowing you to incorporate it into a potential subsequent oncoplastic operation. And as part of surgical planning, most B3 lesions are non-palpable, therefore determining the best method for localization, either based on imaging features or what residual lesion you have, or even what resources you have locally available. Now, pre-operatively, the operating surgeon should really themselves review the pre and post biopsy imaging, which includes any imaging you have, whether it's the mammogram, ultrasound scan, and MRI scans. You really want to determine if there is a residual lesion and if the clip is actually in the correct location. If you think the clip has migrated, you certainly do not want to localize the clip, but instead you really want to localize the lesion or the calcifications. So intraoperatively, as my previous colleagues mentioned, depending on the size of the area, you really want to appropriately sample the index area. If you have a small area, you certainly will aim to remove the entire lesion. You're not really aiming for margins, and you don't need to dissect down onto a muscle like an oncology operation. But it is very important to document the specimen weight and also orientate the specimen correctly for our pathology colleagues. Intraoperatively, you really should do a specimen X-ray to determine if the clip was retrieved, if the lesion or the calcifications were excised. For lesions deemed to be quite high risk, you could consider leaving clips in the cavity, really to guide you for if a second operation, a resection of margin was necessary, or even to guide our radiation oncology colleagues should this turn out to be DCIS or a cancer that's been completely excised. But overall, really clear documentation is key. What you see here on the right is what we use at the Zurich Breast Center. We use the clinic tray where the specimen's been pinned on the clinic tray for orientation. And in your intraoperative X-ray, you can really see the orientation quite well. And these pictures are all saved as part of medical documentation. Now, in terms of localization techniques, wires are well-established localization techniques for non-palpable lesions, so certainly in B3 lesions. We've been doing them for decades, from the early 70s. And all breast surgeons are normally quite skilled at wire excisions. It's important to be aware that you have many different types in the market, and you should really familiarize yourself with the ones that you use at your center. So whether you use the ones with the two-edge tips, or as you see the picture below, that's one that changes caliber as you approach the tip of the wire, and certainly that could be an advantage, and you could use it to really guide you during surgery. Now, placing these wires mammographically, they can be placed by our radiology colleagues in the radiological suite, and then the patient comes up to the operating theater with the wire already placed and secured. The other option is what we actually do at the breast center. We place all the wires ourselves intraoperatively. So during the vacuum-assisted biopsies or core biopsies, a ultrasound visible clip is placed. We use a hydromark gel clip. And after anesthetic induction, when the patient's asleep, we use an ultrasound scan and place the wire in and localize the clip ourselves. We then we mark the lesion and the clip, and also the incision, as you can see from the photo on the right. I certainly can't emphasize enough how useful having an ultrasound scan in the operating theater is for a surgeon. I certainly learned my ultrasound skills in Switzerland, where I am expected to do all my own diagnostic ultrasound scans, interventions that includes biopsies of breast lesions, axillary biopsies, placement of clips in the axilla and in the breast, and also wires intraoperatively. Having the skill under your belt as a surgeon is certainly a huge advantage in surgical planning, and has certainly given me an edge in the management of all my complex cases. Just very quickly to highlight, there are non-wire localization techniques. Some of us may be quite familiar with them. Some of us have used some of them. A lot of the times we use them in the axilla, but certainly for B3 non-palpable lesions, you could potentially use them for breast lesion localization, but they are certainly quite expensive. So I'm just coming up to the last part of my talk, going through some interesting cases, imaging, and some challenges that comes with the surgical approach to to high-risk lesions. So the first thing to highlight is hypertrophic scars. Now, it's important to warn patients who have a tendency to develop these scars that this might occur after a surgical biopsy, and it certainly can occur after even a core or a vacuum-assisted biopsy. If you look at the patient on the right, that's a picture of a patient 10 years after a core biopsy at my center. She developed a huge keloid scar, quite unsightly, which really she's quite unhappy about, unfortunately. Now, the surgical biopsy patients are a little bit more at risk, increased risk of developing the scars, because unlike the cancer patients, these patients may not end up having adjuvant radiotherapy. What we do know is the radiotherapy actually helps or reduces the risk of keloid scar formation. So it's quite important for you to warn the patients beforehand. I have an interesting mammogram, and maybe Dr. Sharma might agree or not agree, but this was an interesting mammogram pointed out to me by my radiologist, brought to my attention about 2 or 3 weeks ago. So in this mammogram, you can see that the clip is localized in roughly about the 7 o'clock position, with the calcifications lying right next to it. But then when you go on to compare this mammogram to the mammograms done previously, you realize actually the clip is lying more in the 5 o'clock position. So on the second inspection of the mammogram done recently, you really realize on the CC view, during the compression, the breast was distorted, and that really displaced the clip completely to a different location on the breast. And when you work in a center where you localize these clips using ultrasound guidance during theater in a very large fatty breast patient, can really throw you off course and cause a lot of confusions in theater. So I think it's really important to know and understand your mammogram, know how to read your mammograms, and identify if the quality is really not at its best. So the clip loss rate, certainly going in, removing, doing surgical biopsies on B3 lesions or even surgical excisions on a non-pulpal lesion, there is a risk of losing the clip. Certainly with B3 lesion, it carries a little bit more of to lead to quite a frustrating situation, because sometimes these patients do not have residual findings on imaging. So you might do your surgical biopsy and then you get a picture like this where the clip has been lost. And certainly as a surgeon, it's very frustrating, and basically you're completely lost in theater. So I think what's really important to know when you do your specimen X-ray and you find that the clip's not in your X-ray, the first thing to do is to remain calm and not to panic, and try to go down a systematic approach. So the first thing you want to do is ask yourself if the index area has been removed. And if you think it has not, then you can attempt an intraoperative ultrasound scan if you have one available. And if you are lucky and you do identify this clip, then you try to localize it with a wire, preferably a wire, if not at least a skin mark. Now, if you can't identify it intraoperatively with an ultrasound scan, then you could try to work it out from your mammogram based on the wire tip and the location of the clip, and perform an intraoperative immediate resection of margin and X-ray the margin to see if the clip's in the X-ray. The clip is still not retrieved, or the lesion is not retrieved. I think the best thing to do with this situation is to bail out and consider leaving some clips in the cavity. Obviously, the radiologically, the Liga clips look different to the localization clips performed preoperatively. And you can then do an early post-op mammogram, especially if your histology is not concordant to the radiological findings. And at this point, you want to warn the patient that there is a possibility that a second operation may be necessary. So this is a patient that we lost a clip on Thursday. So I thought it's quite fresh. I thought I'll bring it in. It's for the purpose of discussion. It's certainly a good example, but it's not a B3 lesion. It's a low-grade DCIS patient. But as you can see, the calcifications are really not very prominent. And following a stereotactic biopsy, confirmed low-grade DCIS, unfortunately, the patient ended up with a large hematoma. And the clip was still deemed to be in the correct location. Using an intraoperative ultrasound scan, you can see the clip is actually lying quite superficial to this hematoma, which therefore carries a higher risk of you losing the clip during the operation as you dissect down the mastectomy plane. And furthermore, if you have a very keen assistant, as soon as you breach the hematoma wall, your assistant, he or she may shove the suction down in your hematoma, and then there goes your clip. So certainly in this situation, replace the wire, remove the lesion, and as you can see, no clip was found. But what we realized on the specimen itself, we realized that the very edge of the specimen where the hematoma started to bleed, started to basically drain out, that we used swabs to actually to collect these pieces of hematoma that came out. And at the end of the operation, we x-rayed the swabs, and sure enough, you can see the clip is actually on the swab. And on closer inspection of the swab itself, we actually identified the clip. It's quite interesting, really, what you can find when you know what you're looking for. So this is an interesting MRI scan. She's a 36-year-old lady who presents with a palpable lump in her nipple. The ultrasound scan and mammogram was completely normal, but on clinical examination, just between your fingers, you can really roll a very small lesion when you actually palpate her nipple. And we organized the MRI scan, which basically suggests a papilloma within the nipple itself, something that we couldn't really radiologically biopsy. So following a discussion in the MDT, the plan is to perform a surgical excision. Unfortunately, I'm doing it next week, so I don't have any intraoperative photos to share. But the operative plan is to do a radial incision on the nipple itself and just work down into to find the lesion. My next case is a 70-year-old lady who presents with a biopsy-confirmed cancer of the left breast that you can see quite clearly here. A MRI scan also suggested non-mass enhancement in her right breast in the 9 o'clock area. Over 15 years ago, she had an excisional biopsy exactly in this area. There's a scar on the breast, and which confirmed a lobular neoplasia. Following a discussion at MDT, the suggestion was for a vacuum-assisted biopsy, and I guess in the UK you would consider that as a vacuum-assisted excision, as about 5.8 grams was removed and confirmed LCIS B3. So following the discussion in MDT, it was deemed that the right breast was certainly based on the guidelines, was suitable for further surveillance, and the left breast we would be doing the wide local excision on. This is the picture of the patient's breast. The patient really, she's 70 years old, very, very fit and healthy, and she wasn't really happy with the breast. She wanted a reduction, mastopexy. So we then planned a wide local excision with a bilateral reduction, and during the planning, we said, well, why don't we then remove the index area that was previously biopsied? Now, localization of this area was a bit of a challenge because the clip had migrated medially by about 7 centimeters. But a very clever radiologist identified a macrocalcification in the area that was biopsied stereotactically. And we then localized the macrocalcification in theater with a wire and removed this area as part of the breast reduction. So the left breast confirmed the NSD cancer. But what was quite interesting is the right breast, the area that was localized, picked up an incidental finding of a 9mm lobular cancer. But overall, the patient's now extremely happy because she's had both areas removed with successful excisions, and she's very happy with her cosmetic results. Owen. Now the next case is quite a complex case, a 51-year-old lady who presented to us in the breast center for a second opinion. Small cluster of calcifications in the 10 o'clock area in the right breast. This was part of a routine mammogram screening. Now, the primary hospital organized an MRI scan and picked up a large area of non-mass enhancement extending all the way up to the axillary tail. So in the primary hospital, a gynecology colleague proceeded to do the stereotactic biopsy, which happens a lot in Switzerland. And when she came to us, she had confirmed high-grade DCIs in the 10 o'clock area where the calcifications were, which were no longer visible given this very large hematoma. But she also had a clip placed at the 12 o'clock area, which was basically biopsied to show FEA and ADH with no mammogram, MRI, ultrasound correlation. So this was quite challenging because comparing this to the MRI scans, we didn't feel that the non-mass enhancement was appropriately sampled. So following our MDT discussion, she underwent an MRI-guided biopsy, which basically revealed a high-grade DCIS as well. So essentially now we have a patient with 3 clips in the right breast, 1 with ADH and FEA, 2 with DCIS. And we discussed this in MDT, and the MDT felt in the fact that the ADH is now neighboring the non-mass enhancement area, which has now been confirmed to be high-grade DCIS, we had to do a wide excision, which essentially is a quadratectomy. So the MDT basically recommended a mastectomy, but given the fact the patient has a significantly smaller breast on the right side, which looks very different to the other side, and she declined a mastectomy and only wanted breast conservation. So it was quite a difficult case to plan. As you can see, this was my preoperative marking the morning of surgery. Using the ultrasound scan, I identified the 3 clips, marked up the area, correlated it with the MRI scan for the non-mass enhancement area. And the only option here was to use volume replacement, which I used the modified LICAP technique. That's a lateral intercostal perforator artery technique described by Farid Maybudi at Westmead Hospital in Sydney. And intraoperative pictures. So we removed this entire area. I raised the flap on the blood vessel and basically used it as volume replacement. So at the end of operation, she had a good cosmetic result. A large area was removed, what we marked, extending all the way to axillary tail. And the histology confirmed a large area of high-grade DCIS, along with multiple papillomas with atypia, FEA, ADH, and radial scar, so the whole combination. She's very happy with the results, so that's a pre-op and post-op results, very early, still quite bruised, brain just removed, but she's certainly very happy that she could avoid a mastectomy. The last case today is a case that I came across as a fellow in Australia. This is a 45-year-old lady we operated on in a rural hospital in Australia without in-house radiological access for localization. So the patient has a localization wire outside. Then she drives herself in for half an hour. And by the time she gets in for a markup, the wire was not identified. So we marked her up. She was having a bilateral breast reduction as part of the operation. And intraoperatively, we performed the ultrasound scan. We could not identify the wire, so we thought it probably had fallen out. We performed the operation, so wide local excision, bilateral breast reduction, and did not come across the wire. And post-op, this is a CT scan of the chest. And as you can see, the wire that was placed in the left breast is now sitting beautifully in the inframammary fold of the right breast. So my last operation in Australia as a fellow after 2.5 years was a wire-guided wire excision, just really for you to show localization can get very complicating. And it's really important to know that if you think something is retained, for you to remove it because it can migrate. So just to conclude, the overall management of B3 lesions can be very challenging. You certainly want good radiopathological concordance. And I think having the MDT to support you every step is crucial. From a surgical perspective, you may be thinking that B3 lesions are where you do your surgical biopsies, but I think every case is very different and it might actually grow to be much more complex than you think. You should be aware of any complications and challenges that you might face and know how to manage them. And certainly at the end of the day, it's all about patient care and providing patient-centered care. So thank you.
Great talk, Kavitha, and many thanks for that. And lots of lovely examples, lots of things on the chat discussing about that example. Do you mind stop sharing the screen, because now it's Giuseppe Catanuto, and Giuseppe is one of the surgeons in Sicily, in Italy, and he's one of the serial offenders here. Giuseppe has been on those webinars quite a few times before, and it's not only about surgery, it's not only about pathology and radiology, it's also about communicating to patients. And that's where communicating B3 talk is about, how we speak to the patients. So Giuseppe, the next 10 minutes are all yours. I'm not sure if you're speaking, Giuseppe, but I cannot hear you. You might be on mute.
Sorry, even after so many times, still not very experienced in managing the Zoom. So sorry. So I remember very well when we discussed the title of this presentation, and I said the title could be Communicating B3. Your diagnosis is not a cancer, and your surgery is not for treatment. So this is a very complex issue because we are somewhere in the middle of nowhere, and we have to discuss how to manage this with a poor patient who had this kind of diagnosis. I can't go ahead with my presentation. I don't know why. Yazan?
It's all working okay, Giuseppe, here. Do you want to unshare your screen and share again and see if that works?
Yes.
So while we wait for Giuseppe to share his screen and retry this again, the next webinar is on the 25th of February. It's going to be in the morning in the UK, 10 o'clock in the morning in the UK, because most of the speakers are from the eastern part of the world. So that's it's about chest wall perforators. But this time we want to see how the things are done in Australia and New Zealand. So we have Alex Brown and Peter Shin from New Zealand. We have Farid Mayboudi from Australia, Melanie Walker is also joining, and we're trying to get some people also from Singapore also to join on that webinar. So it's a completely different timing to see if we can get more work with the colleagues also from Australia. So it's great to have people like Sharon and Owen today joining us, but I know it's past midnight for them, so we're going to try to give the Australians, New Zealand, Hong Kong, Singapore, and all colleagues from that neck of the woods a better timing. So hopefully that will also work for people from here in the Europe and in the Middle East. Let's try again, Giuseppe, and see.
So thank you very much once again. I think now it's fine. So we were talking about something communicating B3, something very difficult because the diagnosis is not a cancer and surgery is not for treatment. And this poor patient, I was saying, has to face two kinds of risk. The first one being an immediate risk. She can have some kind of underdiagnosis. So maybe when she had the biopsy, they didn't get the cancer and they get something close to the cancer. And so she has been underdiagnosed in a way. And the other risk is a long-term risk. After the diagnosis of B3 may be confirmed after further investigation, getting more tissue to confirm the diagnosis, well, in the long term, she can develop a cancer, she can develop breast cancer, she can have a predisposition. So this is something very scary. You have to discuss two different kinds of risk, and within the context of highly heterogeneous group of lesions, as perfectly shown by our pathologist colleague. And obviously, different kind of lesions bear different risk levels and uncertainties, and that means different communication. I'm not communicating in the same way when I have fear. I'm not communicating in the same way when I have LCAS, and maybe pleomorphic LCAS, which is not a B3 lesion, is a B5 lesion. So it's a completely different scenario. I have to explain what is the meaning of atypia, because sometimes atypia is something that changes the management of this kind of lesions. Most of the times, communication can be verbal, and you have your patient in your consultation room and you speak with her, and try to explain all these kind of percentages, numbers, possibilities, histology, different histologies, and on and on. Sometimes, well, it is highly advisable to design specific decision aids for B3 lesions. You know, designing decision aids is quite a complex matter. It's not very easy, because when you design a validated decision aid, you have to, first of all, go into literature and perform a systematic review and get the evidence. And most of the times when dealing with B3 lesions, the evidence is very low and the evidence is of poor quality. So you have to put all together all these, all this information coming from papers, coming from journals, from systematic reviews, with very heterogeneous assessment, and once again, communicate with the patient. So it's, once again, it's very, very, very difficult. It is very important to provide quantitative information, because it has been proven that quantitative information is a quality indicator for decision aids. You have to use numbers, but we know very well, especially in some countries, that people are not used to discuss numbers, to understand numbers. I think that everybody has experienced the problem of ALCL in using implants. When you tell a patient the very low chance she has to get an ALCL using textured implant, maybe sometime the patient will say, okay, doctor, I had breast cancer and I will have also ALCL using implants. The truth is that the risk of getting ALCL is absolutely completely different. In terms of amount of risk, let's say, is completely different from the risk of getting breast cancer and being a female, possibly postmenopausal. Interpretation of statistics can be very difficult, especially when there is a large uncertainty. And obviously, you will see that all the information that we get express the risk in different ways. So you can have hazard ratios, you can have relative risk, absolute risk, and so on. Not everybody is skilled to understand this kind of information, and you have to assess the so-called numeracy of patients, the ability to understand numbers. But obviously, the communication should be a very high quality in terms of frequencies or percentages, should be presented in an appropriate time frame. You have to use consistent denominators, and for instance, you have to tell 15 women out of 100 who had a diagnosis of lobular neoplasia will develop breast cancer in the same breast within 15 years. So very clear information within a very clear time frame. And you have to use, again, consistent denominators. For example, a typical ductal hyperplasia is diagnosed in 3 out of 10,000 screening mammograms. Very clear numerical information. And again, the risk is reported in different formats, which is quite challenging for communication tasks. And also, it is very important to select a proper comparator, because we are talking about different systems of diagnosis, different system of sampling. It is completely different, the upgrade rate, if you're using a VAB or if you're using a core needle biopsy or if you're using a vial. And obviously, one option is also observation. We didn't talk about observation nowadays, but it's one of the options the patient should be informed about. And also talking about excision, our colleague, the surgeon, our previous talk was very, very insightful regarding all matters related to surgery, but we have to talk about also, we have to discuss all the possibility, all the possible complications related to non-operative assessment. And don't forget that sometimes non-operative management, I mean, percutaneous excision, may require very good facilities and very good learning curve before getting optimal results. Personally, I use a lot predictive models. Predictive models sometimes can give you very accurate information that can be tailored and that can be discussed across two time frames. For instance, I like the Tyler-Cuzick model that includes B3 lesions and that provides risk over time in 5 years, in 10 years, or by the time the patient gets the age of 85 years. And that could be very helpful to discuss the level of risk and to discuss the intervention. That could be maybe observation, maybe surgical excision, maybe any other kind of management, including pharmacological management in some selected cases. So uncertainty dominates, and uncertainty can be of two orders. The first one being aleatory. That means that is related to indeterminacy of future. We don't know the future. I mean, it's something that nobody knows. There is another kind that is called of second level, which is epistemic uncertainty. That is the lack of knowledge. When we got our patient in front of us, well, clearly we cannot talk about future, but obviously we have to provide clear information. Otherwise, we will generate adversity and psychological distress. And, and again, we have to manage so many numbers, so many possibilities, so many complex information alternatives. And you don't want to stress your patient for something which is not a cancer at the moment, and for something that is not going to be treated for surgery, with surgery, for instance. And you don't want to generate distress, and you don't want to be looked by your patient and understanding in her eyes, this is not a doctor, this is a crazy man, I don't want to deal with this man, and I will leave him. So if uncertainty dominates, we have to dominate uncertainties. The most important point in the information of B3 lesions is that these are not life-threatening conditions. So despite the high level of uncertainties, the risk, the life-threatening risk for this condition is minimal, as well as the risk of heavy treatments. And you can see, for instance, the database, data from the SEER database, which is showing that 1, 5, and 10 years overall survival for patients diagnosed with LTAS is 19.7, 96.7, 91%. So it's very, very high survival rate. And very rarely these lesions, unless they are part of a misdiagnosis in which diagnosis has not been performed properly, very rarely are associated with complex adjuvant treatments. I have a few additional considerations that are part of discussions with members of patients advocacy organization. And first of all, they are recommending that follow-up surveillance intervals should be represented to patients in order to make a progressive decision. Sometimes, in some specific situations, when there is no concern of highly possible diagnosis of breast cancer, you can give the patient the time to stop and think about. And there is no rush. You have to do step by step, the proper decision, step by step. You may want to provide additional source of information. In this regard, it's very important to provide decision aids once again, but also any other kind of visual information with, with video or with interviews with experts. Let the patient be totally aware about this condition, and possibly allow for follow-up meeting in the short term. Okay, this is the diagnosis, take your time, we'll see in 2 weeks, in 3 weeks, and so on. Have a second opinion if required. And once again, it is recommended by the patient's advocacy organization to allow the patient not to come alone for a second consultation, and have someone with you that can help you in understanding better this diagnosis. So I have to acknowledge the support of Dr. Marta Zambon, who is the Executive Director of Europadonna Coalition, that assisted me in doing this presentation, especially on this final section. And thank you very much for your attention. Let me invite you to visit my new unit. I've just started a new job still in Sicily, in Catania, in a very good in a very good breast unit, which is one of the largest in southern Italy, with USOMA certification and part of the European Commission Initiative of Breast Cancer. So I hope to see you one day in Sicily in very nice and sunny days, even though today is raining. Thank you once again for your attention.
You're muted, Yazan.
It's your time now, Yazan, muted.
Oh, I'm not used to use the iPad. Sorry for that. So I'm muted, and I got a message. It was in front of the unmute button. I couldn't unmute it. Sorry for that. So if we put all the cameras on again for also Kerstin and Omar, and we start the discussion. Now, there's lots of points in the chat function, people asking about the certificates. So everybody that attends the webinar will have a certificate. And we have 1.5 CPT points by the Royal College of Surgeons of Edinburgh. I usually send the certificates about a week after the webinar. If you haven't received your previous certificates, please check your spam email. It comes from a Gutenberg certificates on behalf of iBreastBook. If you still cannot find it, just send me an email at info@iBreastBook and we can sort that out for you. There's few points that have been raised in the question and answer section. And there's a comment by Veronica. Veronica, you asked about AR and VR in breast surgery. Just email me. So I'll direct you of who to ask about that. Now we'll start with the discussion. So we've heard the lovely talks by everybody, but we did not hear Kerstin, Owen, or Sharon at all talking today. So we need to see any points that you want to raise before we start the questions. Owen, Kerstin, and Sharon. Owen, you're unmuted, so I think you want to speak first.
Oh, I don't know if I want to speak first, but yeah, look, I have to say, I don't know if there are any other Australians or North Americans online. Our breast screen approach is a little different, and perhaps we're a little bit further behind than the Europeans and the British. We still tend to do more open biopsies, but I think also it depends on patients' perception of risk. Also depends on the medico-legal environment in which we work in, and as Giuseppe said, is that explanation is very, very important. I think we're probably going to trend that way, but at the moment our breastfeeding recommendations are still for open excision. I guess one way that we've approached that is that using seed technology does reduce that that risk, that extra step associated with surgery. And again, it comes down to, I sit on a medical indemnity board, and I do a lot of medico-legal reporting for delays in diagnosis. And I think it's just a case of getting that perception across to patients. So I don't disagree with anything that has been said at today's webinar, but I will just say that, we are slightly behind in Australia in terms of our non-surgical intervention.
It might be different practices, Owen, but that's the beauty of the webinars. You have people from different parts of the world, and the practices are completely different. So it was great when Nisha mentioned that other parts of the world still do lots of surgical excisions. It's mainly time saving, and it's mainly the process here in the UK that we do lots of large volume excisions, because that will free the surgeons to do more of the more excisional work. But that's why we have all of you from different parts of the world to see how the practice is different. Sharon, is the practice different where you work also?
Sorry, are you asking me? Sorry.
Yes. Do you do still lots of large volume excisions for B3 lesions, or do you still do lots of surgical excisions?
So I think in Hong Kong, we are following UK is becoming more conservative, especially with the availability of vacuum-assisted excision. And we are doing more and more percutaneous excision. And it seems that our pathologists are now more confident in giving us diagnosis of benign pathology if there's no atypia found. And I think the talk today is really excellent. I think there are 2 points that we need to stress. One is the MDT assessment, so that we will know that from radiologically whether the lesions is mostly the amount of excisions, and also the completeness of excisions, and also the presence of atypia. All these add up to whether the lesions can be follow up or not, or need a further excision for diagnosis. And also the last thought is also very, very important, how we communicate with the patients. And I think the patient's preference is very important. Some patients will just want every lesion to be excised, even though you tell them that it is benign. But some ladies, they would just don't want to have any surgery, even that they know that there is a risk to carry on. And they would like to, they can bear the risk. So I think in Hong Kong, we are having more and more B3 lesions being follow up, especially if we can excise it with the vacuum assisted excision. Yes.
That's great. And Kerstin, Sweden and the Scandinavian countries have some of the best databases in the world. And what do you do in the Karolinska? How would you deal with the B3 lesions?
We would certainly, I think, mimic most of what the UK and have presented here. I think it was a fantastic presentation, and it really highlights what the possibilities in the future are. So we use exactly the same process with core needle, vacuum excision, biopsies or excisions, and we don't follow our patients so often, but we follow, after having excised, we follow them 6 months, and then they go back to screening. I think what Sharon mentioned is concordance, of course, concordance with imaging and pathology, and that is, of course, extremely important. And if you have anything that is more mimicking a phylloidous tumor, I think then it's really something we are not prepared to vacuum excise. We would certainly be more up to surgical excisions. We are not as, I think, as aggressive as Australia. So the less invasive we can be, that's, I think, the preference. I think there are regional differences in Sweden.
That's great. And Omar, in Egypt, I don't think that you'll do as much screening as Europe, but you still have a screening program. You still see those lesions. So is the practice different? And is it different in other parts of the Middle East? Because you have very good connection with different parts of the Middle East.
Yes, we already started the screening program, and we are seeing a lot of the B3 lesions now for the pathology. And we are still far behind, not like UK, but I would say we go for the surgical biopsies. And this was going to be my question to Nisha, because she mentioned that 80% of the cases in UK are treated by the vacuum-assisted biopsies. What about the other 20% that why they are not following the UK guidelines? Because I know also that in UK, everything is very well calculated as cost effectiveness. So in my country, I would say that the vacuum assisted would be much more expensive than going for an open biopsy, open surgical biopsy. So I want to know what's the comment by Nisha.
Yeah, so just to explain, when I said 80%, what I was talking about is the initial biopsy. So I absolutely agree with you. Vacuum-assisted biopsy is more expensive than performing conventional 14-gauge biopsy. But in the UK, because people have made a natural transition from doing core biopsy to doing vacuum-assisted biopsy, X-ray guided, but we still have about 20% of units that are still only doing core biopsy first line. And we cannot recommend first line vacuum assisted biopsy because we know where they're performing core biopsy, they are getting calcifications in over 90% of cases. So even though everyone recognises that vacuum-assisted biopsy is the better biopsy in terms of quality of tissue and the likelihood of having a definitive diagnosis, we cannot in the UK mandate that everyone does vacuum-assisted biopsy first line. But because of the guidelines that we've developed, we can insist that we treat these high-risk lesions with vacuum-assisted excision. And this is driven by the patients as well, because patients don't want to go for surgery unless they have to. And so if they're in a hospital that doesn't offer vacuum-assisted excision, then they have to refer to a neighbouring trust that does. So, so from that point of view, we have made huge progress by developing the guidelines for managing the high-risk lesions.
Thank you.
There is always in the high-risk lesions, what I find very strange up to a certain extent is that the risk is not in the first 5 years. The risk is more 10, 15 years after, especially with LCIS. And we get this B3, we hoover it, Abeer tells us, oh, it's all out. And then we just decide high-risk surveillance, which is mainly 5 years, and you stop doing the mammograms. But there is no point because their risk is really, they get the cancers 10, 15 years down the line. Follow up those patients in Australia, for example.
Hi, yes, I think just to end
my
again,
line is
just yeah, Owen here. Yeah, just to give that alternative view, I guess the sorts of lesions which are a very low risk of upgrade, such as radial scars and papillomas. I guess one approach is that with an excision, we would discharge those patients. They need no follow-up at all. So when you're factoring in costs, I guess you've got to factor that cost of follow-up as well. Also second procedures. So I think moving across to seed technologies means that, you know, we're not putting in wires on the day of surgery in some of our units. But I think the point that Yazan makes is important when you're discussing risk with the patient. It's years over years following at risk. So if the young person who intuitively you may want to be more conservative with are going to be living life at risk for many more years than the older patient. So we're more likely to be more conservative with the older patient than with the younger patient.
Yazan, are you okay?
I don't know if Yazan
I'm
is.
okay. I think my internet went down. Are you all okay?
We are all okay.
No,
Yes.
I'm back. Are you all hearing me okay?
Yes.
Yeah, so many years
Giuseppe,
ago.
I put you as a co-host because my internet dropped down.
I think it's fine now. We can go ahead.
Many years ago, Yazan,
great.
we did quite a lot of work using the large core biopsies. That they've actually faded into non-existence now, but that was a technique that actually was able to remove lesions entirely with margins. But that sort of technology no longer exists. You've actually, but we do employ vacuum-assisted biopsy quite extensively in our workup.
Kerstin has her hand raised.
Yes. I was wondering, yes, thank you. Nisha, could you comment on anything about breast density? Because some of these lesions may have been discovered and diagnosed, and then you have a patient with dense breast. Can you comment on that and the management, especially we raised the topic about follow-up?
Yes, so the follow-up question is a difficult one and very important. So at the moment in the UK, lesions with no atypia do not have follow-up because they go back into the screening programme. Lesions with atypia, we offer annual mammographic follow-up for 5 years, and then they go back into the screening programme. Now, we are collecting data. We're doing with them a bit of work looking at whether that's necessary. I do think that 3-yearly or 2-yearly screening programme would probably be sufficient, and you don't need the annual mammographic follow-up. Now, breast density is really interesting because in the UK, we don't record breast density within the screening programme. And the reason that we don't do that at the moment is because, first of all, it's a very subjective process. So it's the radiologist would read the mammogram to decide how dense the mammogram is. And as we all know, that's very subjective as a process. So the breast screening programme doesn't record breast density. However, we know that with breast density, you can get a masking effect. So, and remember that just because you see calcifications, you can have DCIS, which isn't calcified. You can also have high-risk lesions that aren't calcified. And that's one of the reasons that you want to do the further sampling. And that's why when you get more tissue, whether it be vacuum-assisted excision or surgery, and it still remains benign, then you've done what you can. Yes, the woman is at increased risk of developing cancer 15 to 20 years down the line, but by doing a surgical operation, you're not mitigating that risk. So we have to remember these women do not have cancer. It's benign. And we need to minimise over-treatment of these benign lesions. They are at increased risk, but we should pick that up through our screening programmes. And that's what we have to educate our women about, that by having a surgical operation, they are not going to reduce the risk of getting cancer in 15 to 20 years down the line. Because remember, historically, all these patients were managed with surgery prior to vacuum-assisted excision. So I think Giuseppe's presentation was excellent. I think it brings in the patient and it's about giving them the correct information. And I think sometimes the anxiety is there when the patient says they want the operation is because they think they've mitigated all the risks. And that's often not the case.
Thank you very much, Nisha. I think that, well,
that's great. I don't know if you can hear me all okay.
Yes, we can hear you, Yazan. You can go ahead. Yazan?
So I was going to ask Abeer if you can hear me. Abeer, one pathologist ADH is another pathologist DCIS. Any comments about that?
Yeah, I think we know that we are not very consistent in AGH diagnosis, and basically it's just because it's a quantitative one. So you need to see a lot more tissue to be certain that's all what it is, because we rely on the extent and on the size. And there are several definitions of what's the difference between AGH and DCIS. So some use the 2 fully involved ductal spaces. Some use the 2 millimeter cutoff. Sometimes if you do levels, the lesion gets bigger and then you diagnose DCIS. This is one of the lesions that lacks consistency. And that's where pathologists need to maybe take a second opinion or discuss among each other and reach a consensus. However, if we stick to the guidelines, to the really what the definition is, it shouldn't be that problematic. It's sometimes that when you have a spectrum of change or FEA merging with AGH and then DCIS, sometimes these are the difficult ones. But that's where pathologists need consensus. If there is doubt, we take another opinion and reach a consensus before giving the final verdict to your surgeons. I think Giuseppe was planning to
yes.
comment. Yeah.
I had a comment for Nisha, for Kavitha as well. I think that there is an issue about learning curve, either on the surgical side and on the percutaneous excision side. For what concerns Italy, well, in my unit, which again is a top level unit, we have very well equipped. We have all the device to perform vacuum assisted excision. We have radiologists, not only one, but more than one radiologist who is trained to do vacuum assisted excision without complications, with the right indication. But it's not the same everywhere in Italy, I can say. And also the surgical management, and this is my question to Kavitha, the surgical management can be different and requires a specific knowledge. It's not like doing cancer, and you have to be careful, like you are doing cancer. I mean, it's the same. You have to develop specific skills. You are doing an operation on the breast. You may need, as Kavitha has already said, you may need to perform another operation for cancer purpose. But this is a completely different technical skill in terms of localization, in terms of planning of excisions, and on and on and on. So can you comment on this? Learning curve, Kavitha and Nisha.
All right, thank you, Giuseppe. Yeah, I completely agree with you. I think a surgical excisional biopsy can actually sometimes be a lot more difficult than your wide local excision biopsy. Certainly surgically more challenging, a lot more at risk, because if you lose the clip and you can't localize the lesion, you're doing an operation that removes some bit of tissue that might come back as completely benign, and then your MDT or pathologist saying, well, there's nothing here. It just adds a lot of risk, and then you're taking the patient through a second operation, and what Nisha actually mentioned, well, and then they all come back benign, and now you put the patient through multiple operations. And I think it's very important to really know this operation very well. And you're absolutely right, starting training, a lot of trainees start on surgical excision biopsies because it's deemed to be the less sort of serious operation compared to a cancer. But actually I completely disagree. I think it's actually a challenging operation. Sorry, Nisha.
May I ask, if you have even large volume excision available, will you excise the papilloma with atypia surgically or radiologically? I don't know, what would you do?
We would excise it surgically because that's our recommendation, because I know that people have published saying that they can perform vacuum assisted excision, but that's not what the question is. The question is being able to diagnose the DCIS. And certainly when we develop the guidelines, and Abeer can come in and explain this better than me, but our pathologists clearly stated that they wanted the lesion excised whole. And therefore, that's the reason in the UK, the guidelines are clear that if you have a papilloma with atypia, you should do surgical excision. And that was because of the pathologist, not because we couldn't perform vacuum assisted excision, but because of the pathologist.
But that's a message. That wasn't because in many places, including where I work, sometimes they want to go for a radiological excision, but if you cannot take it in entirety, that papilloma, you cannot see a 3 millimeter area or the entire papilloma, you can miss the DCIS. Am I correct in saying that, Abeer?
Exactly. You need to assess it in continuity to measure 3 millimeter or more. And in fact, most of the guidelines in the world, like the German guidelines, the European, still recommend excision for papilloma with atypia. But for them, it's based on the upgrade rate, which is again more than 10%. So they would still recommend surgical excision. But for us in the UK, you really need to assess it intact to make sure that whether it is 3 millimeters or more to diagnose DCIS or not.
And also sometimes in the discussion, the MDT, I don't know if you all have that. Sometimes you have AIDPH, or AIEDP, or whatever you have changed the name of ADH to now. Now, if it's on the edge, you don't know if it's 3 millimeters or more, or 2 millimeters or more. You don't know if it's DCIS. So if it's not in the center of the specimen, then you cannot assume it's not DCIS. Am I correct in saying that?
I mean, you need to assess the whole area because you add them together as well. So sometimes you have 2 ducts in the original and then another 2 ducts. So together they would amount for DCIS. But that's why we cannot call it ADH or DCIS on the original code because we don't know what's remaining there. Is it 2 millimeters or not?
You're becoming more like dermatologists. Long names for many things.
but yeah, I think that bringing back to your point, whether it's the age of the lesion, that also depends on what's your imaging finding. So,
yes.
For example, for my patient, she had a very large area of non-mass enhancement seen on the MRI scan. So certainly that was the thought that the ADH probably caught the edge of the lesion rather than actually a true representative of the lesion itself.
So I don't know, Kerstin, Sharon, and Owen. Sorry, I got disconnected. The Wi-Fi is not great here, so I changed to a different computer now. How long will you follow up those patients? And will they have? Will they be under the surgeons in the follow-up because they're under the surgeons with the radiological follow-up where I work, or will they be under the radiological follow-up? So how long will you follow those patients up, Kerstin?
We would do a survey of 6 months. And if nothing then, and it's the radiologist actually who does it, and then they go back to screening. So I think that we have the cutoff. It's whenever atypia, we would surgically excise, and with no atypia, we would have a control after 6 months, and then we will give them back to screening. Because if you look at our national data for screening, it's 64% of all cancers are diagnosed by screening.
Any difference the way you do it, Owen, in Australia or Sharon in Hong Kong?
Yes, and as you know, as I said, we probably do more surgical excisions, but if it's so for the B3 lesions, I would return them to screening, and certainly for the B3s that are things like radial scars, papillomas that are proved to be papillomas and not DCIS, etc., they just get discharged and go back to routine screening. And LCIS, again, depends on the age of the patient. So we know it's a long-term risk. If it's a young person, we might just recommend more regular surveillance, but it's something that screening can deal with, I think.
Yeah, for Hong Kong, we are having similar with Kerstin that say for atypical lesion, mostly we will have it excised. But if for with B3 lesions with no atypia, and we will go for MDT again. And if surgeons commit that most of the lesions excised by vacuum assist excision, we will just follow up the patient 6 monthly for 2 years, and then go back to routine screening. Yeah, so it's 2 to 3 times follow up, and to see if the lesions, if all the abnormality, imaging abnormality are excised or not.
That's great. I think just a couple of comments. If somebody has a hematoma, There was a comment from Ernest Luton. I had breakfast with Ernest, now he's back in Emirates. So if you have a bit of a hematoma post biopsy, most of the time you just wait for the hematoma to settle down. Is there any cutoff time that you'll stop waiting and you start doing the excision? Because sometimes that might complicate things. You might end up taking much bigger area for something completely benign. I don't know how anybody wants to comment on that. Because we need it at least 6 to 8 weeks time and then have a look again. It's a benign thing, even if it's small low-grade DCIS. There's no harm in waiting.
Correct. I think we wait 3 months maximum.
Yeah. And
it depends on the size of the hematoma. Say if the hematoma is not big, we can excise the whole hematoma of the lesion. But sometimes it did happen that the hematoma is huge and we can't do any surgery, just wait for a few months. But mostly after 3 months, the hematoma will be resolved. But I think it's most importantly to prevent the hematoma formations. Most of the time after vacuum-assisted excision, we will, besides compression, we will let the patients to wear pressure garment for a few days. We will let them bring the pressure garment home. And with that pressure garments, we see very few hematoma complications. Yeah, so the more important is to prevent the hematoma formation.
And Giuseppe, as you mentioned in your talk, it's all about communication. And I think it's very important to communicate to the patient that, yes, you're at high risk, but your high risk might be years down the line. And some people might want to, because they'll have more, they just need to have their scans maybe a bit longer. I think the 5 years, you'll miss most of the diagnosis. Am I correct in that or not? Because if you have LCIS, your risk is not in the first 5 years, is it?
Sorry, I missed few words.
So if you have LCIS, for example,
yes,
your risk of getting an invasive cancer is not in the first 5 years. Your risk is usually around year 10 plus. So is that something that needs to be communicated for the patients?
Well,
so
it
that
is something
might
that
encourage them to attend their screening.
Well, absolutely needs to be communicated to the patient, but needs to be communicated in an understandable way. Yeah. And everybody is subject to the risk of, female are subject to the risk of breast cancer. And maybe in this subgroup of patients, the risk can be a little bit higher. And we need to perform some more examination and more strict follow-up. You have to be clear, precise with numbers, but at the same time, you have to be very informative that this is not going to be a life-threatening condition. You can manage this condition. You have it, you can handle it, you can keep it under your control. This is the information we are going to provide patients. Now, for what concerns Italy, the situation is very heterogeneous because we, in some areas, we have very well-developed screening system with a lot of control and again, very trained radiologists that can perform vacuum-assisted excision easily and without complications, managing very well. In the rest of the country, in some areas, especially in southern Italy, is not the same. And you definitely need skilled surgeons, but also skilled radiologists to perform vacuum-assisted excision. And sometimes surgical excision is still a single chance. And again, you have to balance communication. You have to inform the patient. This is what we have in our hands in this facility. This is the best opportunity I can provide to you.
That's great. Apologies for the technical problem because I was really locked up for about 10 minutes. So I lost bits of the discussion. It was my fault. We're nearly coming to the end of this because it's nearly 7 o'clock. Is there anything that anybody wants to comment on? Is there any points that you want to raise as speakers and panelists?
Yazan, it's Nisha. I just wanted to say that It was made in the question and answer session that someone had raised the point that we're trying to do active surveillance for low-grade DCIS. So we've got the UK trial, European trial, the trial in Japan, trial in the States, where we're trying to be conservative to minimize overtreatment and talking about active surveillance for low-grade DCIS. And yet, for these high-risk lesions, which aren't cancers, we're pushing for surgery, you know, and this, to me, again, is a conflict, because for something that isn't a cancer, we're being quite aggressive in how we manage it in terms of ADH. And yet for low-grade DCIS, we're saying we're happy to monitor it. And no wonder people then get confused. So I do think we need to align our thoughts and management of these conditions, and just remember that high-risk lesions are not cancers until they've been upgraded to cancers.
Kerstin, you have your hand up.
Yes.
Did you want to say something, Kerstin?
Right. Yes, and on that same topic, because these are not cancer, I don't think tamoxifen is a valid treatment option for B3 lesions. I just want to make that comment because that was in the chat box. Thank you.
That's great. And any other comments from any of the other speakers?
Yeah, I just want to add to this as well that we even have trials now excising small low-grade cancers, like the small trial by vacuum-assisted excision as well. So it makes sense that we are going conservative, and it doesn't make sense to keep excising benign lesion. Final point is that in the UK guidelines, when we have extensive calcification, a large area, particularly over 3 centimeters, we start by sampling 2 areas. So we sample more than one, because as you said earlier, you might get ADH, but if you sample another area, it might be actually the edge of a DCIS. So the most suspicious 2 areas, and then sample. Subsequent management depends on the histological findings.
That's great. And we're nearly coming to 7 o'clock UK time. Any other comments, or shall we close this? I think if there is no other comments, on the 25th of February, it's 10 o'clock in the morning. I know it's still be very late for you in Australia, but it's not 3 o'clock in the morning at least. It is chest wall perforators flaps revisited. That it is not completely finished the program, but we have from New Zealand, which will be nearly midnight for them. We have Alex Brown, we have Peter Chin, we have Peter Barry is also speaking, though he's in London, he's Australian. And we might have also, we have Farid Mayboudi also from Australia, and we're trying to get also Gyok Hun Lim from Singapore to speak about chest wall perforator flaps. We've done the chest wall perforator flaps before, but mainly UK and European speakers. This time it's going to be a complete different cohort of speakers, and it will be interesting to see if they do it differently, and I'm sure that we'll learn lots from that. That will be at 10 o'clock in the UK in the morning in UK time. For tonight, I cannot thank you all enough for taking the time, being part of the speakers and the panelists, and of course, everybody that has joined us tonight, more than 600 people. I'm really sorry for the technical problems, but I hope that you have managed to get the most out of this today. So for people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the Middle East and the subcontinent, have a good night. And for people in Australia, have a good morning. You're nearly there, Owen, isn't it? And,
yeah, Yazan, thank you for your great chairmanship, and thank you everybody for a wonderful forum. We've all learned a lot, and please think about the BSI. It's a great international forum. Yeah,
it's a great forum, and thank you for being part of this as BSI. Thank you.
Well,
thank you, everybody.